Hello, hello. Can you hear me?
Can hear you.
Hi, can you guys see my screen? Hello, hello.
Can see? I can see the screen.
Okay. You guys seeing the screen in the presenter view or in the normal screen view? Like you can see notes, ka?
Cannot see notes.
Can I see notes? Okay, can. Nice. So how was on call, bro? No, I'm kidding. Nobody is here yet.
Okay lah. Ming Huang patient a lot of problem.
Oh. GG.
They will ask a lot of difficult questions, right? If
I
they
don't
do
know,
like that, topic like macam quite. Bro, you leave until when, bro?
2 days only, bro. The next week.
Next week lah.
Yeah, as we come back, cause I never taken leave in as a MO before. First time. I try taking leave.
Feels good, right? Feels good lah.
Yeah.
Feels good to take leave. sorry.
So Hello guys, can you guys hear me?
Yep, can hear.
Okay, all right. Hi, very good morning to everyone. Good morning to Dr. Lim. I'm Stephen and this is Jonathan. And today we will be presenting about the approach to pancytopenia. So the outline of this presentation would likely be about how do we actually approach pancytopenia, and we'll give some examples or some case scenarios regarding patients with pancytopenia and how we arrive at the diagnosis for the pancytopenia. So first things first, what is the definition of pancytopenia? So pancytopenia is the decrease in all blood, peripheral blood lineages, which is the red blood cell, white cell, and platelet counts. So just basic information, lower limit of HB for female is 12, for male is 13, and the lower limit of white cell is 4, neutrophil count is 2, as well as the lower limit of platelet is 150. Okay, so pancytopenia is defined when all these three are actually below the normal reference range. So the causes could be actually due to one of these, either impaired production, peripheral consumption, or both impaired production and peripheral consumption. So the causes of impaired production can actually be differentiated into either malignant or non-malignant causes. Okay, so for malignant causes such as leukemia or lymphoma or metastatic cancer, they can actually cause pancytopenia. And the non-malignant causes might include some non-nutritional like aplastic anemia, MDS, infection, HIV, Hep B, EBV, storage diseases, and congenital bone marrow failure syndrome. And nutritional causes can happen as well. So the B12 folate deficiencies, alcoholism, or any malnutrition can actually cause a pancytopenia. So just a side note, right? Because B12 deficiency is not only can cause a megaloblastic anemia, it can cause a pancytopenia as well, because the cells, the body have actually less B12 to work on for the maturation production of the three cell lines. So cause of peripheral consumption might include DIVC, hypersplenism, as well as some any autoimmune disorders such as SLE-RA or FELT syndrome. So in this case, actually the production is actually not impaired. It's just that there's some peripheral consumption by the hypersplenism or DIVC that causes the pancytopenia. The bone marrow itself is actually intact and doing fine. And also a combination of either of both impaired production and peripheral consumption, such as PNH. So PNH is actually paroxysmal nocturnal hemoglobinuria. It's the characteristics are actually hemolytic anemia, some hemoglobinuria, and some maybe thrombosis, maybe, but chiari. So it's caused by the lack of the GP1 in the cell surface, causing all the hemolytic anemia, hemoglobinuria, and thrombosis. And drugs, SLE or HLH, are the causes of both, one of the causes which involve both impaired production and peripheral consumption. So, and let's talk about the congenital bone marrow syndromes. So just a quick recap of what is Wiskott-Eldridge syndrome. So Wiskott-Eldridge syndrome is actually a combined B and T cell dysfunction. It's X-linked recessive, and it's characterized by some recurrent bacterial infection, some eczema, thrombocytopenia, and low IgM levels. And Fanconi anemia is autosomal recessive, and patients will present with some short stature, thumb or radius abnormalities, or some cafe outlet spots, which are associated with aplastic anemia as well. So dyskeratosis congenital is just a form of bone marrow failure in which the marrow cannot produce red blood cells, basically produce sufficient blood cells. Schwann-Diamond is actually is associated with pancreatic dysfunction with malabsorption, growth failure, as well as some pancytopenia. Yeah, and GATA2 deficiency is just a germline disease in which the GATA2 is deficient, so couldn't really provide. It couldn't really synthesize all the cell lines. So these will be more. I believe the Pete's Medical would understand more about this. Yeah. So other notable drugs or toxins that we should be aware of when we saw a patient with pancytopenia is methotrexate, azathioprine, mesalazine, NSAIDs, carbimazole, hydroxyurea, deferiprone, and Bactrim. So usually it's actually a little bit idiosyncratic or peculiar, because this kind of pancytopenia might develop within 4 to 6 weeks. So it's worth monitoring the FBC for a longer period of time when we start a patient on, let's say, methotrexate at first. Yeah, and so once we know patient we have pancytopenia, so how do we define it as emergency, and when do we refer to a hematologist straight? So these are some of the emergencies in pancytopenia that we should be aware of. So neutropenia with fever or infection, symptomatic anemia with cardiac ischemia, hemodynamic instability, or worsening heart failure, thrombocytopenia with bleeding, DIC, abnormal peripheral blood smear, which includes like some blast, severe aplastic anemia, which I'll talk about later, HLH, as well as any metabolic emergencies, okay, tumor lysis syndrome, hypokalemia. Anytime we actually encounter one of these, we should like kind of consider whether to get a hematological consultation. Yeah, so signs and symptoms of pancytopenia it's basically just about like the loss of 3 cell lines, okay, the symptoms that they produce. So anemia will cause lethargy, dizziness, dyspnea, chest pain, and claudications. Lack of white blood cell will cause recurrent infections. Lack of platelet will cause a bleeding tendency and easy bruising. So however, from the signs and symptoms, you can also pick up maybe some patients have some underlying condition as well, such as some joint pain, malaria rash for SLE, any jaundice, nausea, vomiting, abdominal distension for patients with cirrhosis with portal hypertension, which causes hypersplenism and is a peripheral consumption causes of pancytopenia, and as well as some constitutional symptoms for patient with malignancy. And all in all, patient might be asymptomatic as well. So just you can sometimes you just pick up pancytopenia from a patient who is totally asymptomatic. So past medical history is also important, whether the patient has any history of SLE, disseminated TB, cancer, chemotherapy, radiotherapy, aplastic anemia, or MDS before. Drugs, as I mentioned before, are also very important part of the history to find out the cause of patient's pancytopenia. So as for examinations, so rashes, you might find a patient with rashes which is related to drug reactions, rheumatologic disorders, some infection, or malignancies. So oral lesions, oral thrush, you might suggest a patient which is has immune compromise, HIV, oral ulcers, which indicate SLE, lymphadenopathy, splenomegaly, lump masses, which can indicate any malignancy. Or any peripheral consumption, jaundice, or any stigmata of liver disease. Yeah, so all these are actually we really need to watch out and pick up if we are approaching a patient with pancytopenia. So initial workup, first of all, I think we should take a look at the PBF, I mean the basic FBC, RP, and all. Then after that, we should take an urgent PBF for a patient with severe pancytopenia. And blast will indicate there's a leukemia. I'll show some examples later. And if patient have macrocytosis, so we should consider some megaloblastic, aplastic anemia, or MDS. So other investigations that we can go for is like B12, folate, iron studies, ESR, CRP, AFT, viral screening, and autoimmune CD4 CUMS to check for causes of pancytopenia. So this is a normal PBF. So you can see that here. I'm not sure whether you can see my mouse or not. This is some neutrophils with 3 to 4 nuclear loops, which is normal. And the red cell and the platelet is of the normal size and normal shape. Okay. So you can see in this picture is actually a leukoerythroplastic picture, okay, where you can see, right, there's immature myeloid and red cell series. You can see the myelocyte and all is very immature. It's not like the previous picture, and the red cells are actually of a different shape, a little bit immature. So this indicates a bone marrow infiltration or replacement, and it's kind of like the bone marrow was crowded by all these cells, and then it was squeezed to the peripheral blood film. So BMAT is really indicated if you see from PBF, there's a leukoerythroplastic picture, if the causes of pancytopenia is unknown. So this is a very important thing to pick up for us. And blasts, you can see that from here, you can see there are 2 myeloblasts, okay? So which is quite large cells with some high nuclear to cytoplasmic ratio. And each of them has actually some little pink or red rod-like structure, which is called the hour rod. Okay, so standard MRCP question. This is actually a acute myeloid leukemia. You can see a myeloblast with hour rods in this picture in the PPF. And next, I can see also some hypersegmented neutrophils. It's different from the previous picture because this has more lobes, you know. So it just indicates a megaloblastic disorder. I had to screen for B12 folate, you know. So additional test is actually basically all the tests, right, is we have to titrate the investigations accordingly to patient. So for patient who has like suspicious of TB, then we can lung CA, then we can do a chest X-ray, even a CT, or even a CT-TAP for patient who might have recurrent uterine CA. PSA for like, older patient, older man with no obvious cause of pancytopenia, which might have an enlarged prostate. So we actually have to titrate accordingly. Okay. And next we go to a BMAT, bone marrow aspiration atrophy. So this is we usually this will be done usually by the hemato team, and it's considered when a primary hematological disorder is suspected, like acute leukemia plus anemia or MM. So a primary hematological disorder is suspected, then we should do a BMAT. But it's not really recommended if I mean it's not really. We can't really find any cause if the cause is actually from the peripheral consumption causes. Yeah. So so we do the BMAT. Usually we send to we put a needle around the posterior or anterior iliac crest, and then we aspirate the bone marrow and send for some tests. Okay. So now we move on to some case presentation. So this is a 28 years old lady, non-medical illness and not any medications. Presented to the district hospital with a very high grade fever of 39 degrees Celsius for 2 days. So the HB is 6.5, white cells 2.1, absolute neutrophil count is 0.05, platelet is 9. So she was transfused with platelet and PEG cells, and started cefepime, taken blood CNS. It didn't respond after 2 days, so changed to meropenem, didn't respond as well. So added amphotericin B for day 5, still having fevers with day 8 of antibiotics. Blood CNS negative. So the urgent PBF shows some severe neutropenia and thrombocytopenia, no abnormal cells seen. So usually when there's no abnormal cells seen, you can kind of guess that it's actually not caused by some, and no blast seen, so it's not really indicative of any leukemia, you know. So, but however, we referred to a hemato team, and then we did a BMAT, and from this you can see that actually there's virtually no hematopoietic cells seen. Okay, it's only consists, the marrow space only consists of fat and stroma. Okay, so this is normal BMAT. Okay, so normal BMAT has around a cellularity of between 30 to 70%, and the remainder is being occupied by fat and stroma. So compared to this and this, this has severe, I mean, lack of cellularity. It's very hypocellular. Okay, so we can see from this is a very severe aplastic anemia where the hematopoiesis is markedly suppressed. Okay, the definition of aplastic anemia is defined as a pancytopenia with hypocellular bone marrow in the absence of any abnormal infiltrate or marrow fibrosis. Okay, so there are actually three diagnoses or criteria that we should be aware of. So it's either the first is aplastic anemia diagnosis. At least 2 of the following: HB less than 10, platelet less than 50, or neutrophil count less than 1.5. So severe aplastic anemia is when it has a bone marrow cellularity of less than 25%, plus at least 2 of the following: neutrophil less than 0.5, platelet less than 20, or reticulocyte less than 20. So, and very severe aplastic anemia is severe aplastic anemia plus the absolute neutrophil count less than 0.2. Yeah, so the pathogenesis of aplastic anemia is actually an antigen-driven and likely autoimmune dysregulated T-cell hemostasis, result in hematopoietic stem cell injury. And the treatment I'll just briefly go through. So treatment for patients, I think in Malaysia, less than 40 years old, then we would actually can try to have a matched sibling hematopoietic stem cell transplantation. Okay, if you manage to find a suitable donor. Okay, but however, if patient is more than 50 years old, or patient who has no identical sibling donor, we might have to consider some T-cell suppressive agents such as the ATG, horse anti-thymocyte globulin, cyclosporine therapy as well, with maybe some eltrombopag as well. And if the treatment doesn't work or there's no response in 3 to 6 months, we might actually consider whether we want to have an unrelated donor to find the unrelated donor for the hematopoietic stem cell transplantation. Okay, for children, we can also, we will put more emphasis on the children so that they can have how to find a suitable donor for them for the hematopoietic stem cell transplantation as well. Yeah. So next, pass the mic to Jonathan, and you talk about the next cases. Thank you.
Yeah, good morning, everyone. I'm Jonathan. I'll continue the presentation with a few more cases. So this is a 80-year-old lady, bedbound in nursing home actually, presented with lethargy and mild jaundice noted by the carer there. So examination-wise, the vitals actually stable, thin, pale, tinge of jaundice, no lymph node palpable, no hepatosplenomegaly. So, yep. So investigations-wise, we can see that the FBC is HB is 6, total white count also low, platelet is low as well. MCV is noted to be elevated. Reticulocyte count is 0.5%. Total bilirubin is raised, indirect, predominantly is the indirect bilirubin. LDH is high as well. Then we took the anemic workup. B12 iron is normal, B12 is 50, folate is 10. The renal profile is normal. So in the PBF, you can see this hypersegmented neutrophils. As Stephen has mentioned, the normal neutrophil lobe is around 3 to 4. So this is definitely more than 4 lobes of the we can see. So I'm sure you all know the diagnosis already. For this patient, it will be a megaloblastic anemia secondary to B12 deficiency. So what you can see, how do we usually diagnose B12 deficiency? Mainly through there'll be a low B12 level, raised LDH, raised indirect bilirubin, and also macroovulocytes. And the causes of B12 deficiency you can just briefly divide it into like problems with the food, stomach, or intestines, or even the drugs. So food will be decreased consumption, vegan diet, very common in elderly. There's this cobalamin malabsorption as well. Stomach, mainly the pernicious anemia, atrophic gastritis, Zollinger-Ellison syndrome, H. pylori infection. For the gut, the intestines, it'll be celiac disease, any of those malabsorption, HIV infection, bacterial overgrowth syndrome. So all this will cause the decreased absorption of vitamin B12 and drugs as well, metformin, which we don't commonly see, I assume, and also proton pump inhibitors as well, because we need the acid as well to help absorb vitamin B12. The other investigations to consider if you're thinking about pernicious anemia will be the anti-intrinsic factor and also anti-parietal cell antibodies. Yep. So we can see in the next slide there is so you can see there's a normal PBF is on the left side. Then the hypersegmented neutrophils, which we have already seen. And you can see the macroovulocytes. Macroovulocytes are basically oval-shaped red blood cell, which are enlarged, larger than the normal RBC. So this is what you see in a peripheral blood film. So just a slight explanation on how, just a recap on how does vitamin B12 cause this anemia. So basically, it is B12 and folate is actually folate can also cause macrocytic anemia as well. So basically, it's important in the DNA synthesis. You can see that the B12 is in between the methionine cycle and the folate cycle, the yellow one, between the yellow and the blue. So so the key intersection of the vitamin B12 occurs and folate occurs at the methionine synthase reaction at the left edge. You can see in between the yellow and the blue. Okay, so if this then if the vitamin B12 is not present, then the methyl THF cannot react and change to THF, which in turn will lead to impaired DNA synthesis. So that's why there is also called there'll be nuclear maturation problem in this uh, vitamin B12 deficiency. So the treatment for this kind of vitamin B12 deficiency, we can either give IM or subcut cyanocobalamin 1 mg once per week, up to 4 weeks, then once per month. And after that, we monitor the vitamin B12 level and also the FBC to look at the response. So the next case, you can see this is a 30-year-old male presented with feeling unwell for the past 2 weeks, spontaneous bruising, past 2 weeks fever. On presentation, he looks septic looking, BP is 90/60, heart rate is 112, SpO2 is 95% under room air. There's an ejection systolic murmur. On abdominal palpation, there was hepatosplenomegaly, no lymph nodes, no other lymph nodes can be palpable. HB is 6, low, and then total white count is 1, and platelet is 9, so quite severe anemia, pancytopenia. And then on examination, you can look at the you can see that the mouth of the patient, there is some what you call necrotic patch as well, so on the lips and also the tongue. So next, and then we can see in this examination of the skin, there's this disseminated erythematous papulonodular lesion in. So this is so there's this disseminated erythematous papulonodular region. And then next slides, we can see also there's gingival infiltration and this papulonodular lesions as well. So this is quite classical of acute leukemia, acute leukemia, which we'll see in this patient, acute myeloid leukemia or acute monoblastic leukemia. So thereafter, obviously, we send a peripheral blood film. You can see that there's a high nuclear cytoplasmic ratio with reduced cytoplasm. So you can see, I think this is the same picture that Stephen showed as well. I got 2 myeloblasts, and then so one thing you can also appreciate is the high nuclear to cytoplasmic ratio and the nuclear life, and also the rods with the pink rod-like structure in the cytoplasm. So that's what you have to see. So this is the diagnosis will be pancytopenia due to acute myeloid leukemia. The management will mainly be IV antibiotics because of the low neutrophils. Transfusion with platelet and PEG cells. We need to do a BMAT to confirm our diagnosis, and also proceed with the chemotherapy. That's in a very general sense of the treatment of acute myeloid leukemia, how we approach. Okay, then the next case is a 24-year-old male. So fever, rash, anasaka, hepatosplenomegaly. BP on arrival, not that great. Heart rate is 110. Saturation still maintaining. Noted the HB is 9.7, white cell 2.7, platelet 72. Absolute neutrophil count is not too bad, 2.3. Slightly elevated AST, ALP. Ferritin is 14,000, LDH 2,100, which is elevated. Fibrinogen is low. So in this case, and then we took peripheral blood film, couldn't see anything very extraordinary. So we proceeded with bone marrow biopsy. And we can see in this bone marrow biopsy, we can see the hemophagocytosis, which basically means the macrophage has engulfed the RBC. So the black arrow is showing the RBC inside the macrophage, which means it's already engulfed. Okay, and you can see, yep, that's and the next picture, you can even see a clearer picture. You can see the phagocytosis of the nucleated red blood cells. The red arrow shows the nucleated red blood cells, and the black arrows, you can see the platelets all engulfed by the macrophage. So all is inside the macrophage. So I think you all know the diagnosis already. This will be a hemophagocytic lymphohistiocytosis. So a bit on this, it's basically a aggressive and life-threatening syndrome of excessive immune activation. So it can be either familial or sporadic. Infection is a very common trigger in this case. Because it's quite rare, so sometimes we don't think of it at the back of our mind when we approach a pancytopenia case. So next slide, we can see that so here shows the causes that can be a primary or secondary HLH. So primary usually is familial and is usually due to a genetic mutation, and secondary is can be due to viral infection, malignancies, autoimmune or autoinflammatory conditions like SLE, systemic sclerosis, and other causes like malaria, enteric fever, leishmaniasis, and dengue as well. So many is a hyperinflammatory condition leading to a cytokine storm. So it can be primary and secondary. And next. So just briefly on the pathophysiology. So as I said, it's a hyperinflammatory condition. In primary, there's genetic mutation. Secondary, there is a trigger that leads to pro-inflammatory cytokines release. And these cytokines will activate or more so overactivate and proliferate the macrophage, leading to hypersecretions of the cytokine storm. Then after that, there will be phagocytosis, where the bone marrow, where the macrophage just engulfs the precursor red cells and also the platelet as well in the bone marrow. So all this cytokine storm will lead to fever, lymphadenopathy, hepatosplenomegaly, multi-organ failure, and hyperferritinemia. So next slide, we can see how to diagnose. So there's two ways to diagnose. One is H score and one is HLH 2004. So this H score, there are a few parameters. You can see there's underlying immunosuppression, and with this score, with more than 169, suggests a positive diagnosis. So you have underlying suppression, whether there's a fever, organomegaly, how many lineages of pancytopenia, how high is the ferritin, what's the triglyceride, fibrinogen generally is low. Look at the AST, ALT, and also the hemophagocytosis on the bone marrow aspirate. So the next we can diagnose this is using the HLH 2004 diagnosis criteria, which if you have a molecular diagnosis which shows the genetic mutation, or if the patient fulfills 5 out of the 8 criteria below: fever, splenomegaly, cytopenia, is almost the same as the previous one, hypertriglyceridemia, NK cell activity, ferritin, and SCD25, the receptor. So how you diagnose HLH. Next is the treatment. This is the overview of the treatment. Basically, we can see that if it's a primary cause, then many treat using the HLH94 protocol, which comprises of dexamethasone, etoposide, cyclosporine, and plus minus intrathecal methotrexate, followed by a hematopoietic cell transplantation. If it's a secondary cause, we mainly treat, depending on the trigger, basically all patients will receive steroids as well. Mild cases, we just treat the underlying condition. We might not need to proceed with the HLH protocol, but if it's more severe case, we might need to use the HLH protocol, etoposide, cyclosporine, and methotrexate or alemtuzumab and tacrolimus. So stem cell, this hematopoietic cell transplantation is only for refractory disease. So the next slide we can see basically this is the HLH 2004 protocol. There's a protocol for it. First we give Dexa high dose, then after that we pause every second week. Then subsequently we give etoposide, and then after that cyclosporine, and then intrathecal therapy. And obviously the definitive will be a stem cell this one hematopoietic cell transplantation. So with that, I end the presentation. Thank you all for listening. Any questions?
Hello, can you hear me?
Yes.
Yeah, we can hear.
Hi, thank you, Stephen and Jonathan. It's quite an informative presentation. I think it's quite important as well because I think pancytopenia is quite common nowadays. Yeah. So if there's any question, anyone just can just speak out or just type in the box.
Dr. Lim, I got one question. The SCD25 soluble interleukin 2 receptor and also the NK cell activity, do we have that test in our setting?
Don't think so. Actually, I don't know what is that also, and then we never use it. But most of the time, as you know, there are two criteria, right? We think the H score is better than the HLH 2004 criteria. So when you see the H score, I don't think they have, right?
Yeah, H score don't have. Only the HLH more high.
As we know, the HLH 2004 is actually more towards for study. It's actually an inclusion criteria for the HLH study, the HLH 2004 study, but because it's quite easy to use 5 out of 8 criteria, then you can sort of include the patient into that study. So doctors tend to use that to diagnose HLH because it's easier than the H score, which you need to count, and then more than 169 is diagnostic like that. But preferably we use the H score. Yeah.
Oh, okay. Thank you, Dr. Lim.
Yeah, so I don't think we have the CD25 or the NK activity. Yeah.
Oh.
Okay. Dr. Lim, I think in the chat box, I think Pua asked about whether there's any threshold value for transfusion for pancytopenia.
Depends which cell. For platelet wise, if less than 10, we tend to transfuse, especially when the patient came acutely and we are not sure what's the cause. So if no bleeding, we use threshold of 10 for platelet. And if for HB, depends on the patient, usually we take 7.
Okay. And for the next question, Dr. Wong Waikit asked about can hydrocortisone be used for HLH?
Actually, we tend to use it as well because usually we are not sure whether this is really HLH or not. And then the patient also having severe sepsis with septic shock. We tend to also try to give some steroid and see whether they respond, whether the cell counts respond or not. So yeah, we tend to use it. because sometimes when the patient is severe sepsis, it's not so, how to say, not so easy to start DEXA, because DEXA might be very immune suppressive for the patient, and it might worsen the situation as well. And then, as you know, like especially for secondary HLH, which is more common in the adult setting that we usually see. So in the acute infection, so sometimes we tend to use hydrocort instead of DEXA in the initial phase. Yeah, and until we confirm what's going on. Yeah.
Okay. Boss, I think they asked quite long question in the chat box. Do you mind reading the chat box? I'm sorry, boss.
Okay.
Yep.
And I would like to. Okay, optimal time for BMAT, right? From Ben. We would say ideally the patient should be stable, at least not on very high oxygen setting. So usually, if really in acute leukemia, the blast percentages are high, especially like more than at least 20%. We can send for peripheral blood for immunophenotyping to sort of like categorize what type of leukemia, is it myeloid or lymphoid, and we can also start treatment based on that first. And platelet count is not our consideration when we do BMAT. Even in some patients, pancytopenia, platelet less than 10, 5, 6, like that, as long as the patient is not having like bleeding tendencies, bone marrow is actually not a very dangerous procedure. And then we can always like top up platelet if really bleeding after the procedure. Yeah.
Okay. And boss, I think Paul also asked about one question: is danazol actually helpful in the aplastic anemia? I actually.
Yeah. We tend to use the danazol as well. Yeah. But of course, the pathophysiology for aplastic anemia is actually more towards an autoimmune disease. It's a T cell dysregulation causing T cell injury to the stem cell, and so your bone marrow is not producing. So the treatment is actually immunosuppressant. Or of course, if the patient have a HLA identical donor, then it's an emergency and you need to send the patient early for stem cell transplant. So I think danazol also works in the same way as an immunosuppressant, so in the body convert to sort of steroid. Yeah. So and then you will try to suppress the immune injury to the stem cell. And then also it will stimulate the marrow to produce cells. Any other questions?
Boss, I got one question. When do we generally consider using the granulocyte stimulating factor?
I think this is a very important question because every time when the patient having pancytopenia or like at least like neutropenia, then we tend to get referrals for GCSF. But if you see the real indication for Dupuytren or the GCSF is actually chemo or drug-induced neutropenia. It's actually not for neutropenia due to sepsis or due to immune disorder like SLE, all those, because they tend to sort of like activate your immune system. So it may cause more harm than good actually. Yeah. So the real indication is actually more towards chemotherapy induced neutropenia.
Oh, okay.
Yeah.
Thank you, boss.
And especially in the acute setting, we need to rule out leukemia, because if you give Neupogen in a patient with hematological malignancy, especially leukemia, it tends to cause more blast to come out from the marrow as well. Yeah, so it's very important to get a PBF lah. I think just now, Stephen presented a slide on the initial investigations. I think, yeah, I've gone through that. I think it's quite important. These are the list of investigation to take. But I think most important one is when the patient come in when patient presented initially, most important is get the PBF first to see make sure to rule out any signs of hematological malignancy, leukemia, like that. Yeah.
Both for last question, has just curious actually, has actually BMAT, right? Has it? I mean, is it common for BMAT to be inconclusive, or like it's always actually kind of quite sensitive or specific for us to diagnose what patient has, or? Or like.
Of course, we don't simply do BMAT if it's only if we suspect some, especially hematological malignancy, or some, especially for infiltrating malignant disorder like your lymphoma, and then you can't really biopsy the lymph nodes, very small lymph nodes, and then you think this is due to lymphoma. So, and then the cell counts are low, so you think there's marrow infiltration, and bone marrow might give us an answer. And sometimes we think this like many times rheumatologists also refer to us for bone marrow biopsy, because of course patient got pancytopenia or any cytopenia that they think might not be only due to the SLE or any other rheumatological disorder. They might ask us to do a bone marrow to see that if there's any primary marrow dysfunction. So we can also offer, but of course there are times that bone marrow might not give us an answer, but at least it can tell us, and we can also inform the patient that it's not leukemia. There's no malignant signs of malignancy, and then we can further work out from there, lah. Yeah.
All right. Thanks. I think that should be all. Any more questions from the floor? Okay, if there's no question, thank you, Dr. Lim. Thank you, everyone. We'll be ending our presentation. And have a nice day.
Thank you, Dr. Lim. Thank you, everybody.